A 45-year-old female hailing from Srinivaspur, Kolar, who is a homemaker belonging to lower middle class according to modified Kuppuswamy classification, came with the chief complaints of an ulcer over the inner aspect of the right cheek since 2 months. Coming to history of presenting illness, patient was apparently normal 2 months back when she noticed a small ulcer of about 1 into 1 centimeter, which has now grown to a size of about 2 into 2 centimeters. She also complains of intermittent pain associated on chewing, which is not radiating. There is no history of excessive salivation, no foul smelling discharge, no difficulty in speaking, no ear pain, no decreased mouth opening, no history of hoarseness of voice, no lesion on the skin, no loose tooth or sharp tooth, no trauma to the skin, no ill fitting dentures, no masses in the neck, no complaints of cough or dyspnea, no complaints of backache, no complaints of weight loss. Coming to past history, she does not have any comorbidities like diabetes, hypertension, tuberculosis, or asthma. There are no history of prior surgeries except to tubectomy 20 years ago. She has a menstrual history, coming to menstrual and obstetric history, she is a perimenopausal, para 2 living 2 with regular cycles. Coming to personal history, she has a habit of keeping betel nut, she has a habit of betel nut chewing since 15 years. She also has a history of keeping the quid overnight in the right buccal mucosa with slaked lime. Her sleep is sound, appetite is normal, bowel and bladder habits are regular. There is no history of malignancy in the family. Coming to general physical examination, she is moderately built, moderately nourished, conscious, cooperative, and oriented to time, place, and person. Her pulse rate is 82 beats per minute, BP is 130 by 90 mmHg, SpO2 is 98% at room air temperature, she is afebrile. Her weight is 52 kgs, her height is 150 centimeters, BMI of 21.09, BSA of 1.45 meter square. There is no pallor, no icterus, uh, there is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. Her performance status is ECOG 1. Coming to local examination, on inspection, the mouth opening is adequate with around 3 finger breadths. Oral hygiene is fair. There are tobacco stained teeth, but there are no loss of teeth. There is a single ulcero-proliferative lesion that is seen in the right buccal mucosa, which is circular to ovoid in shape, about 2 into 3 centimeter, which is around 3 centimeters from the right commissure, around 4 centimeters from the upper GB sulcus, and 0.5 centimeter from the lower GB sulcus, and 2 centimeter from the right RMT. It is appearing free from the skin. The the ulcer has a margin which is rolled out, edges which was everted, and floor appears to be filled with necrotic material. There is no discharge or visible bleed present. There are no other lesions in the oral cavity. The movements of the tongue are normal. There are no masses. There are no visible masses in the neck. Coming to palpation, inspectory findings are confirmed of a size of 2 into 3 centimeter lesion in the right buccal mucosa. There is mild tenderness present on palpation. There is no local rise in temperature. It does not bleed on touch. Skin is free from the it is free from the underlying skin. There is no sharp teeth in the oral cavity, and the neck nodes are not palpable. Jaw movements are normal. No mandibular tenderness present. I would like to do an ideal, but it is not done in this case. Coming to systemic examination, cardiovascular system, both the heart sounds are heard. There are no murmurs heard. Coming to respiratory system, bilateral air entry is equal and normal. Vesicular breath sounds are heard. And coming to per abdomen, it is soft, no organomegaly present. So, coming to central nervous system examination, there are no focal neurological deficits. Summary from the history and examination: a 45-year-old perimenopausal female with a history of tobacco chewing since 15 years comes with a complaints of ulcero-proliferative growth in the inner aspect of the right cheek. With no comorbidities. So, my provisional diagnosis at this point would be carcinoma right buccal mucosa CT2N0M0. I would like to go ahead and do routine blood investigations first, like complete blood count, liver function test, renal function test, serum electrolytes, coagulation profile, and serology. I would also like to do a punch biopsy from the edge of the lesion, from the most representative part of the lesion. I would like to do imaging that is contrast enhanced CECT head and neck with puffed cheek. I would also like to do chest X-ray, PA view, and ultrasound abdomen and pelvis for metastatic workup. For management, I would like to advise the patient to advise the patient first on tobacco cessation, maintain oral hygiene, send the patient for dental prophylaxis, and also advise on speech and swallowing exercises. I would like to go. I would like the patient to go ahead with wide local excision with pectoralis major myocutaneous flap reconstruction and supraomohyoid neck dissection. And the other um, then I will wait for post-op histopathological report. If there are indications like extracapsular extension and margin positive according to Bernius and Cooper's et al., I would like to consider for adjuvant chemoradiation. Chemotherapy being cisplatin weekly 40 mg per meter square, and adjuvant radiation being 60 gray in 30 fractions using IMRT technique. My volumes would I would first like to start the planning for the radiation, starting with the simulation, the patient in the supine position, shoulders pull down, thermoplastic cast from head and neck region with marking the bony prominences, and then a simulation scan, 5 cuts from the vertex to the lower border of lungs. Then I would like to go ahead with contouring the my volumes would be the post-op bed as CTVP, which receives 60 gray to 30 fractions, and ipsilateral 1B to 3 level as CTVN, which will receive 54 gray in 30 fractions. And then I will give a 0.5 centimeter margin to them and give it as PTV, planning target volume. I would like to go ahead and evaluate the plan, and then during the treatment I would like to assess for and manage the acute toxicities accordingly, then follow up.